At first glance, this may look like a simple white cataract, but on closer examination, we can see an inferior vascularized corneal opacity reducing our visibility, iris pigment deposits on the endothelium, and central anterior capsular fibrosis, which can increase the risk of an uncontrolled extension of the capsular axis. The pupil is only moderately dilated, and because the patient is receiving treatment for prostatic hyperplasia, we should also anticipate possible intraoperative floppy iris syndrome, progressive meiosis, and iris prolapse. Now we're creating the capsular axis because of the central fibrotic plaque. We're simply going around it and continuing the axis through the healthier peripheral capsule. We're avoiding pulling on or manipulating the fibrotic plaque itself, as this could transmit unnecessary traction on the anterior capsule and make the tear more difficult to control. Here we're adding some cohesive OVD before continuing the axis. Whenever the axis stands to run toward the periphery, it's always wise to stop, reform the anterior chamber with cohesive OVD before continuing. After careful hydrodissection, we're gently bringing the nucleus out of the capsular bag and into the pupillary plane. Here we notice iris prolapse through the main incision, which we gently reposition with cohesive OVD. Now we're proceeding with the flip and the chop technique. We're embedding the phaco-tip into the nucleus to achieve a firm hold and slightly elevate the nucleus. We're then passing the chopper behind the nucleus and bringing it toward the phaco-tip to split the nucleus into smaller fragments. The fragments are then progressively emulsified and aspirated. Because part of the phacoemulsification is being performed relatively close to the corneal endothelium, it's always wise to consider adding dispersive OVD for additional endothelial protection when needed. Using the phaco-tip, we're now bringing the last nuclear fragment toward the center into the pupillary plane and emulsifying it in a controlled manner. Then, during cortex removal, we're carefully monitoring the axis edge and the mobility of the capsular bag, especially inferiorly behind the corneal opacity, looking for any evidence of zonular weakness or zonular dialysis. At this stage, we also notice a small iris prolapse through the side port. Fortunately, the capsular bag remains stable with no evidence of zonular weakness or zonular dialysis. Then, as we're withdrawing the instruments, we notice iris prolapse through both incisions. Again, we're gently repositioning the iris with cohesive OVD, avoiding unnecessary mechanical manipulation. We're proceeding with the bag implantation of the monofocal acrylic lens. We're then carefully removing the remaining OVD and performing stromal hydration of the incisions. Finally, we're completing the procedure with an intracameral antibiotic and subconjunctival injection of dexamethasone. The capsular bag remains stable and the surgery is completed safely. Thank you for watching.